Welcome to our video on eclampsia, acute fatty liver of pregnancy, and chronic hypertension. Let's get started. Here's our overview slide. You can see the list of topics we'll be discussing in this lecture, and let's begin with eclampsia. Eclampsia is preeclampsia with severe features and superimposed seizures. In other words, it's characterized by all of those clinical manifestations that we discussed for preeclampsia with severe features. Additionally, women with eclampsia have generalized tonic-clonic seizures, usually lasting less than 1 minute, and a post-ictal state. Hyperreflexia and visual disturbances like scotoma are also seen. Scotomas are single or multiple black spots in the patient's visual field. Here we see the visual field of a patient with scotoma, and notice the black spots in the visual field, for example right here. This is a patient with a tonic-clonic seizure. On the top of the image, you can see the tonic phase with increased diffuse muscle tone, while on the bottom you can appreciate clonic jerking movements. The diagnosis of eclampsia is mostly clinical. It should be suspected in patients with preeclampsia and seizures when there is no other neurological condition that could account for the seizures. Nevertheless, we see bilateral frontal and occipital lobe edema on CT scan of the head. The treatment includes antihypertensive medications, magnesium sulfate for seizure prophylaxis, and immediate delivery of the baby. Okay, now let's talk about acute fatty liver of pregnancy. Acute fatty liver of pregnancy is a fulminant liver failure due to fat deposition. The clinical features include nausea and vomiting, accompanied by right upper quadrant and epigastric pain. Lab findings in acute fatty liver of pregnancy can be explained by acute decline in liver function. High bilirubin is due to impaired bilirubin conjugation and secretion. Therefore, the patient will have mixed hyperbilirubinemia. High aminotransferases are due to hepatocellular injury. Hypoglycemia is caused by disrupted glycogenolysis and gluconeogenesis. Finally, DIC is caused by unregulated activation of coagulation factors released from the liver. Since this is a pregnancy-specific life-threatening condition, treatment is immediate delivery. Okay, let's try a question. A 31-year-old G1P0 female comes to the physician at 35 weeks of gestation, reporting nausea and vomiting for the last 2 days. She also complains of right upper quadrant abdominal pain. She has never had similar symptoms before. Her ALT is 3,000 and her AST is 2,500. Her total bilirubin is 15 and direct bilirubin is 7. Blood glucose is 65. What is the best next step in the management of this patient? All right, this patient presents in her 3rd trimester of pregnancy with nausea, vomiting, and right upper quadrant abdominal pain. Her ALT is 3,000 and her AST is 2,500. She also exhibits mixed hyperbilirubinemia because direct bilirubin is approximately 15% of the total bilirubin. Her blood glucose is slightly low as well. This presentation is consistent with the diagnosis of acute fatty liver of pregnancy. So the best next step in the management of this patient is immediate delivery. Here we see a liver biopsy image showing lipid droplets and hepatocytes. Although a biopsy is rarely needed in acute fatty liver of pregnancy, this is what the liver would look like in this condition. Okay, let's move on to chronic hypertension. Chronic hypertension is characterized by systolic blood pressure of 130 or greater, or diastolic blood pressure of 80 or greater before onset of pregnancy or before 20 weeks of gestation. In other words, if a woman with no prior history of hypertension develops high blood pressure within the first 20 weeks of pregnancy, she's diagnosed with chronic rather than gestational hypertension. There is usually no proteinuria or acute end organ damage. Subacute and chronic end organ damage, such as slowly progressing kidney disease, may be present. If chronic hypertension is diagnosed before pregnancy, it can be treated with either ACE inhibitors, ARBs, thiazide diuretics, or dihydropyridine calcium channel blockers. However, since most of these drugs are teratogenic, chronic hypertension during pregnancy is treated with either hydralazine, alpha-methyldopa, labetalol, or nifedipine. Okay, let's wrap up with the last topic, chronic hypertension with superimposed preeclampsia. This is characterized by systolic blood pressure of 130 or greater, or diastolic blood pressure of 80 or greater before onset of pregnancy or before 20 weeks of gestation. These are the findings of chronic hypertension. After 20 weeks of gestation, the clinical features of preeclampsia complicate pre-existing hypertension. Specifically, there is an increase in blood pressure to more than 140 over 90 millimeters of mercury. There is also moderate to severe proteinuria with possible end organ damage. So basically, chronic hypertension with superimposed preeclampsia means just that, preeclampsia superimposed on chronic hypertension. As you can see, the treatment for chronic hypertension with superimposed preeclampsia is exactly the same as that of chronic hypertension. All right, now that we've covered the information, let's wrap up with a final question. A 20-year-old G1P0 female at 38 weeks of gestation is admitted to the emergency department due to generalized tonic-clonic seizures that started 1 hour ago. She takes no medications other than prenatal vitamins. A previous prenatal visit revealed severe hypertension, 4+ proteinuria, and pulmonary edema. Her current vital signs include a temperature of 37 degrees Celsius, a blood pressure of 170 over 120 millimeters of mercury, a heart rate of 94 beats per minute, and a respiratory rate of 18 breaths per minute. The patient has a repeated seizure in the emergency department. Which of the following is the best next step in the management of this patient? A. IV labetalol, B. IV magnesium sulfate, C. IV terbutaline, or D. IV normal saline. All right, this patient has severe hypertension, 4+ proteinuria, and pulmonary edema. Additionally, she has a generalized tonic-clonic seizure. This presentation indicates a diagnosis of eclampsia. The first priority in eclampsia is to terminate the seizure and then deliver the baby emergently. The first-line drug used to terminate seizures in pregnant women with eclampsia is IV magnesium sulfate. So the correct answer is B. Recall from this slide that the treatment for eclampsia includes IV magnesium sulfate. Okay, let's discuss why the other options are incorrect. Option A, IV labetalol, is incorrect because although it will be given urgently to this patient with eclampsia, the first priority is to terminate the seizure and then we can deal with their hypertension. Option C, IV terbutaline, is incorrect because eclampsia is managed with emergent delivery of the fetus. Terbutaline, on the other hand, is tocolytic and therefore it will delay delivery. Finally, option D, IV normal saline, is incorrect because it's not essential in this particular case. It's more important to terminate the seizure first rather than to give her fluids. So again, the correct answer is option B, IV magnesium sulfate. And that concludes our lecture.